Thank you for the good presentation. My question is to Professor Carl. Now, I've just seen a video clip last night about people crossing the street in New York. That was 1930. And none of them was overweight, be it obese. Now, the situation now is different. So what happened? And what the disease of diabetes, was the virus which is expanded or something else? Please.
I think that's a very important point, so what we see in our environment today is we see far more people with obesity now, and even if you look at what's happened in Kuwait, when you compare that, to 50 years ago. Now, of course, what we have seen is that the environment has changed, we have air conditioning now, we don't walk anymore, as we did. So those environmental factors, we think, has probably changed the subcortical areas of the brain. So effectively you had environmental insults on the organ that is responsible for how much adipocytes your body wants to carry. And therefore the environmental impact has been very important. But the thinking up to now has been, if we change the environment back, then we may be able to reverse the problem. But many of you treat people with hypothyroidism. So we know that if somebody develops hypothyroidism, very often their weight goes up. But even when you change the environment of the thyroid and you make people euthyroid, their weight does not come down. So my suggestion is that we have tried very, very hard in many countries in the world to change the environment. We built more cycle lanes, we make people walk, we encourage people to exercise, we encourage people to make better diets. But when we've done that, it has not been successful, or not as successful as we want it to be. So in the same way as we see the impact of hypothyroidism changing and making people use thyroid doesn't fix the problem, now what we are seeing, if we use nutritional therapies, pharmacotherapies or surgical therapies, and we treat those parts of the brain, the subcortical areas of the brain, then people naturally go to a lower weight because we are treating the organ that has the disease. And I think our thinking is not perfect yet, and there's lots of more work that needs to be done. But I think the evidence is reasonably clear that only changing the environment is not going to treat the disease of obesity in the majority of people. But I'd like to hear what Alex thinks, and then also Gertrude, on whether or not changing the environment will be enough to treat the disease of obesity in people with diabetes.
Well, probably it doesn't mean that we should not try to change the environment, okay? So by what I mean by that is that we need to adopt some preventative measures in order to reduce, to a certain degree. It is difficult to know how much, but to reduce how many people are going to develop the disease of obesity and or diabetes in the future. But this needs to be done in an understanding way of the disease. The other thing I wanted to say is, in response to that specific question, is that what has changed between the 1930s and now is obviously the environment. No one is going to have any issues with that. But what is important is to always remember that in the same environment, even in the same room that we are today, we all have got completely different weights. Yes, our BMIs are completely different, even though we are surrounded by exactly the same environment. And the important thing to realize that approximately 70% of that variability is not caused by the environment, but it is caused by our own biology, meaning that those of us that have obesity and those that do not, we do not differ in terms of how intelligent we are, and we do not differ in how disciplined we are, but we largely are different in the genetics that contribute to the disease of obesity, or of being completely normal, even though we are surrounded by the food around us.
Any more questions, please? Yeah. Mike, can you please pass on the mic to him?
Regarding tirzepatide, we know it has two molecules. One GLP-1 agonist, which has effect on weight loss, and the other GIP, and the effect on is lipogenic. How can you explain the effect of tirzepatide in a whole more potent regarding weight loss than other, which is only works on weight loss only? Yeah, GIP increase lipogenesis, but GLP-1 decrease lipogenesis. How can you explain the more weight loss with this?
That's a very good question, and one we were just discussing before we started the meeting, and I think there's going to be a symposium or a session on tirzepatide specifically. And I think the true answer is that we're not entirely sure. Okay. But there are some theories that the GIP, number one theory is that GIP makes the GLP-1 part of the molecule even more potent. So GLP-1 on its own has got X potency, and the GIP part of the molecule makes that potency X plus Y. Okay, so that's one hypothesis, that the GIP just potentiates the effect of the GLP-1. The second hypothesis is that it's based on the fact that we don't really understand the effect on GIP, not on diabetes, we do, but on appetite regulation. We don't. And it appears that, and some of the results are conflicting. One hypothesis is that this continuous stimulation of GIP causes functional, as it is called, antagonism of the receptor, the GIP receptor. And what we have got, the evidence that we have from animal studies is that GIP antagonism can cause weight loss. So these are the two hypotheses that at least I'm aware of at the moment.
Question from the fourth row, please.
Yeah. Thanks, Dr. Alex, regarding your answer for my colleague, Dr. Ali. But one point here is important to mention is the use, if you remember, the use of teriparatide in management of osteoporosis. We are using PTH-related peptide, despite PTH original action is osteoporotic one or bone-losing one. But if you are giving, the theory behind that is that if you are going a continuous release without the circadian rhythm of PTH, this would give the opposite effect. For that reason, maybe GIP and the glucagon added to glutatione you mentioned is acting as the same. I mean continuous presence of the molecule in the body would make it against the circadian rhythm of up and down level, which is the original one, in producing the contradictory effect.
And that is a very interesting point. I think what you're saying for glucagon in particular is really, really key. And maybe that's why possibly when we're giving continuous glucagon stimulation, we don't see the effects that we would like to see. But what all of this is also showing us, which is great, is that we are now, and my pharmacology colleague will correct it, but we are now going backwards. So the drug has been developed, right, without us really understanding how it works, and now we're going backwards and trying to understand the mechanism through which the drug works. But we're now in this privileged situation that we can actually learn from the drugs going backwards. We can learn from bariatric surgery. We can learn from nutritional therapies in order to make the drugs even better and make our nutritional therapies even better. So just start praying with changing physiology, which is fascinating to do. And again, that goes back to the fact that by understanding the biology of the disease, we can actually treat it better. If we keep on saying that this is a disease of morality, well, this hasn't worked in the last 50 years in terms of outcomes, and it is not going to work in the next 50 years.
I want to just emphasize the point that Alex made, so we now have these drugs that cause 22% weight loss, but we don't even know, the company doesn't even know how much food people eat when they have this medication. We know the weight loss, but we don't know how people eat. We don't know what people eat. Right? And I think what these tools are going to allow us to do, and I think Jaltrudi's study has shown that also with bariatric surgery, now that we have these tools, we can see how the system changes. And that's going to give us a lot of insight into the disease of obesity. Because, for example, many of us in the room think that these drugs work by making people feel less hungry and making people feel more full. And what Alex has shown is that is true while people lose weight. But what you have heard and I have heard already, 1 year after you give somebody tirzepatide, they come back and say, my hunger is back. I'm eating more food than I have eaten for a long time. The drug is not working. But when you look at their weight does not change. So people will start feeling more hungry on tirzepatide, they will eat more food, but their weight will not change if they continue the drug. And that's what we heard with bariatric surgery, Jaltrudi. Maybe you can comment. Patients come 1 year after the bypass and they say, but the bypass isn't working anymore because I'm hungry and I'm eating more food. But of course the patients can't change the bypass, so therefore their weight remains down. But of course if people stop these medications because they think it's not working anymore, then we lose the benefit. So maybe just, Jaltrudi, a comment on people coming back after surgery and saying, I feel hungry again.
I'd like also to comment about obesity as a disease. I mean, it's like drug abuse, like smoking habit. Everyone knows that if it's smoking, it's very difficult to quit smoking. In spite any effort, which means that, and the same for obesity. People are food abusers, so it is not their fault. It's a disease, as Karen told before. So we need to treat a disease, long life disease. So if we are with hypertension, we have drugs for hypertension, and once we stop the drug, hypertension comes back. Of course, we have to say to our patients that they need to follow the therapy for their entire life, so they cannot stop. The same for obesity. We don't know what happens with semaglutide or tirzepatide in the long run. For instance, a paper published in the Lancet with a 3-year follow-up with semaglutide, half of the patients were lost at the follow-up, which means that many patients can have side effects which they cannot tolerate for in the long run. And therefore, in my opinion, obesity needs to be treated for as long as the life of the patient with different approaches, which can include drugs to help reducing appetite and follow the diet, and minimally invasive surgery, possibly, because of course we know that just 1–2% of all eligible patients undergo bariatric surgery. I'm fascinated by bariatric metabolic surgery because of the effect, of the mechanism of action. Rather, I'm an endocrinologist, so I'm in favor of drugs instead of surgery, of course. But I'm fascinated by the role of the small intestine in the satiety and appetite control, in type 2 diabetes and NASH pathogenesis. So I think that by studying what happens after bariatric surgery, so the exclusion of this part of the small intestine, we can understand and also create new drugs which are more powerful than the one we have.
Professor Mingrawan, thank you for your nice talk, but I thought with the presence of terrorism, I think the role of surgery, bariatric surgery, I thought it should be more or less not to be done, because we have such a good drug. But I think it came in the new area of medicine recently for fatty liver disease, with diabetes. So I thought surgery is less of importance at the moment, and I think bariatric surgery will be, maybe 10 years from now, will be like when you treat gastric disease, peptic ulcer disease. You'll be staying at your office if you are a surgeon, eating donut and coffee,
Yeah.
and then let us treat the obesity and NASH.
I mean, I hope so in the future. We don't know. We have tirzepatide just from when the paper was published in last July, so it's very recent. We don't know what happened, will happen in 10 years. So we need to have the follow-up. And for instance, liraglutide is effective, but of course we cannot reach the effect of surgery. I mean, understanding the mechanism of action, we can create new molecules which can be even more powerful than double agonists like GLP-1 and GIP or glucagon. And of course, I agree with you. I'm not surgeon, so I'm not involved in gaining from surgery.
I want to take the prerogative, if I may address that. So I think I would have agreed with you maybe a year, 2 years ago. My thinking has changed now. So I now think of the disease of obesity in the same way as I think of the disease of anemia. So if you have anemia, and it doesn't matter what the causes of anemia, if you give somebody erythropoietin, you're going to increase the hemoglobin. But if you have anemia because you've got vitamin B12 deficiency, erythropoietin is going to do some benefit, but it's not really going to treat the disease that leads to anemia. I now think that there is maybe 10, maybe 20, I don't really know how many, diseases that all lead to increase in adipocyte mass. And we see those people as obesity. But it's not one disease. It's unlikely to be one disease. And therefore, if we give a hormone combination like tirzepatide, it's like erythropoietin. Everybody is going to benefit a little bit. But what we are seeing is some people lose 50% of their weight, and some people with tirzepatide in the SURMOUNT 1 study gained weight. Even when they were given 50 milligrams of tirzepatide, they gained weight. It's a small number. Because in those cases, like anemia, if you give them erythropoietin, if you've got anemia of chronic disease, it may not work. So I actually think the opposite. I think our surgeons are going to be busier in the next 5 years than they've ever been before. Because now, for the first time, we're going to start treating obesity. And we will find 8 out of 10 people respond beautifully, but 2 in the 10 are not going to respond. But now we've started a treatment program, and we have to do something with them. And I think in the same way what Alex and Gertrude were saying, it's not the patient's fault that they're not responding to the drug, and therefore surgery may be a very good option.
Well, I would like to bet with you on that in 5 years from now or 10 years.
I'll take your bet.
I think we have to move to our key